So good evening, everyone, and thank you for joining another session of LEJEndo. We have been running LEJEndo since January 2023. I think with the exception of 2 months, we've run every month at 6 o'clock UK time, 6th of every month. At LEJEndo, we try and make journal clubs less boring. At least we try. Every month we have a featured article and a few smaller articles, but this month we are going to only do small articles, partly because we had quite a few that we didn't go through beforehand. We had to leave them for later because our featured articles were so interesting that we wanted to discuss them more. Partly because we wanted a different format for this month. I think there are other reasons as well, which I'm not going to go into. So today we've got almost the whole of the CMIC team, past, present, and future, doing the presentations. Pavle Dimitrievich, you've met before. Charlie Cutler is going to present. Flo, the current CMIC fellow. Kyle, the fellow before Flo. And by the way, Pavle is the fellow who would start in 2026. Is that right, Pavle?
Yeah, that's right. Hopefully.
Yeah. Mikey, my consultant colleague, and also Avril will join us a little bit later. Ben will join us too. Okay, so let's go through the papers for this month. Pavle, you're starting.
Thank you. Really nice paper from Horace Rahman and the team that was published in the International Journal of Obstetrics and Gynecology in March 2024. And it's robotic-assisted versus conventional laparoscopic management of deep endometriosis involving the sacral plexus and sciatic nerve, a comparison before and after study. So the objectives of the study were to see patients who underwent excision of deep endometriosis involving either the sacral plexus or the sciatic nerve, and to compare robotic versus conventional laparoscopy outcomes, to assess intraoperative and postoperative outcomes after surgery, and to evaluate the function for these patients for up to 6 months afterwards to see how much we're actually helping them. In terms of the methodology, this was a retrospective analysis of 100 consecutive patients, which was conducted in these two arms, and it occurred from September 2018 until June 2023, with robotic surgery taking over as primary management of patients in October 2021. In both arms of the study, the same steps were used when tackling nodules on the sacral plexus or sciatic nerves, and the robot that was used for operating with the Da Vinci surgical system. Concerning other disease locations, additional procedures performed included surgery on the bowel, ureters, bladder, and endometriomas, including the subtype for what they actually did for the surgery. All patients were given pregabalin postoperatively from days 1 to 13, and in the absence of symptoms, 2 weeks therapy was suspended. Intermittent self-catheterization 5 times a day, combined with medication for 3 months, was prescribed in cases of urinary retention, and self-catheterization was discontinued when a residual volume fell below 100 milliliters. Preoperatively, neurological, gastrointestinal, urinary, and gynecological symptoms were recorded. Intraoperatively, surgical mapping of endometriosis was used using the Enzian and RASRM classification systems, and complications were obviously looking at using the Clavian Dindo system. Postoperatively, questionnaires at 6 months, 1, 3, 5, and 7 years were carried out for these patients. Okay. Very briefly, statistical analysis, they used chi-squared for categorical variables, paired student t-test for continuous ones. Data at greater than or equal to 6 months follow-up was compared, and a p-value of less than 0.05 was considered statistically significant. So what did they actually find? So preoperatively, in terms of the participants of the study, the table on the left, we can see that the two arms were comparable in age, BMI, previous interventions, parity, infertility, and previous ART. However, in the table on the right, we can see that preoperative urinary complaints of dysuria and voiding dysfunction, as well as bloating, were significantly higher in the robotic arm compared to the laparoscopic group. And conversely, the laparoscopic group had a higher number of sexually active patients compared to the robotic one. Preoperative sacral plexus and sacral nerve pain rates were comparable between the two groups. Intraoperatively, the two groups were comparable concerning distribution of ovarian, bowel, urinary, and diaphragmatic endometriosis, barring rectovaginal nodule size, which showed the laparoscopic arm as having a bigger distribution of large disease right uterosacral nodules. The mean operative time was comparable between the two groups, and they observed no significant difference in deep endometriosis nodule distribution between the two groups. In both groups, most patients underwent at least one concomitant procedure involving either the bowel or the urinary tract, and adnexal surgery was performed in roughly a third in both of the arms. Colpectomy rate, though, was higher for complete excision of vaginal endometriosis in the laparoscopic group. Really reassuringly, there were no intraoperative complications observed in the robotic arm, but 4 patients experienced either bladder or vascular injuries in the laparoscopic branch, all of which were managed successfully laparoscopically, with no significant difference in the groups. Post-operatively, once again, no significant difference in terms of complications, and nice to hear there were no conversions to open surgery in either group. Post-operatively, for 90% in the lap group and 83% in the robotic group, we were able to see follow-up for at least 6 months, and the mean follow-up times were 13 and 8 months retrospectively. A marked and comparable improvement in sciatic pain was noted for both groups, and about 30% became completely pain-free in both arms. Unfortunately, the study didn't show any significant improvement in pudendal pain or lower limb motor function in either group after surgery, and urinary function returned in both groups, as well as GI symptoms improving in both groups as well. So the limitations and the strengths of the study. So in terms of limitations, before and after, there was a before and after study design. Therefore, they argue that robotic patients may have been managed with greater surgical experience when tackling sciatic and sacral plexus endometriosis, and there's limited numbers due to the rarity of the disease. However, they argue that this study may well lay the foundations for future larger prospective studies. And the strengths of the study is that even though it is a niche disease, it's a relatively large study compared to the current literature base. Nearly 30% of patients underwent robotic surgery, and it's the first study of robotic-assisted surgery and its use in this disease location. They found that excision of deep endometriosis in these locations is feasible with good outcomes and similar complication rates. And they say that we think that robotic surgery is found to be an excellent tool for fine dissection, but the study doesn't really show that there's a difference in outcomes. And so future studies are needed to consider whether or not there's actual benefits from using robotic.
Pavlik, can you go back on the complication slide?
Yes.
So I don't know if it's possible to zoom in a bit. So yeah, that's good. So looking at the 3B complications, do we have a total of 3B complications at all?
They don't. The main one that they talk about is basically that they find that there's impaired urinary function after both groups for this type of surgery, and they feel that the impaired function was that most of the surgery undergoes involvement of the sacral plexus, which involves the parasympathetic splenic nerves. And they think that the early rate of post-operative bladder dysfunction was reasonable for the study that they had, and that long term they suspect most people get better.
So, because looking here, they are saying that 8% bowel fistula. I'm looking at I think the first column is the laparoscopic group. Is that right? Whole population. Okay,
yeah,
so
the
looking
whole
at the whole population,
yeah,
we had 8% bowel fistula, 4% rectovaginal fistula. Now, I don't know what the difference is here. 5% pelvic abscess requiring second laparoscopy, 1% bladder fistula, 1% vaginal fistula, 1% ureteral fistula. So if you add all of those up, that comes to what, 15% fistula rate.
Mm.
I think that can't be right. Um, it's probably worth
Seems quite high.
yeah, it's probably worth looking at the full text and seeing what they actually mean.
That could,
Um,
I wonder if it's referring to leak with the bowel fistula as opposed to true
yeah,
fistulation.
Mm.
okay, yeah. So yeah,
And then
still,
similarly, I'm assuming vaginal fistula is maybe just a dehiscence. I'm not 100% sure there.
It's
yeah,
difficult as well because it doesn't say whether or not this was if this was an isolated complication in each individual patient, or if one patient had multiple of these complications. So
yeah.
it's
That
difficult
we
to.
had this problem with our 8-year data, didn't we? That we had patients who had one or two different complications, and that's a little bit difficult to put them together. These are very complex operations. You know, you would expect a higher rate of complications in this group of patients. But I'm really not sure. I know this is a very controversial opinion. I'm not sure if comparison between routes is going to be the right way of studying this, because in my opinion, the advantages of robot are difficult to measure in terms of patient outcomes. Um, there is no question that the operation is more precise, the magnification is better, the movement of the camera is less, and you can get to dark deep places much better. You're sitting down, you're less tired. You know, these are the things that I don't know if doing an RCT is going to answer for us. But still, it's interesting to see the results. It's interesting to see the complication rates. And it's interesting to see the bladder atony rates as well, 34%. So that is also an interesting number. Okay. Um, Anything else, guys, you want to add? Mike?
yeah. Pavle, did they look at postoperative pain for those patients? Did they see an increase in pain thresholds straight after the surgery or not?
So they say that in the study they find that there's no significant improvement with pudendal pain in either group, but they do find an improvement in sciatic type pain for both groups. So
Yeah,
in
no,
the
I get that.
yeah.
I get that. My question is that they see increasing pain straight after the surgery for the first two,
I think,
3
Mikey, what they said was that they are giving all the patients pregabalin.
Pregabalin.
pregabalin. But even despite that, they still
Yeah.
haven't seen any spikes in pain that is documented.
None that I can see.
Okay.
Okay. I think maybe it's a good point to go and read the paper for all of us. I think that would be an interesting one. Okay, thank you very much, Charlie. Charlie, you have presented before as well, I think once or twice.
Yes, yeah.
But maybe, you know, not as many times as some of the others. So thank you very much again for doing this, and I would like to see what you're presenting. Go on.
So the first paper that I looked at was the relationship between hypertensive disorders in pregnancy and endometriosis. And this was a systematic review and meta-analysis published by Sharifipour and colleagues in Reproductive Health last year. So the key points from this study, well, the aim of the study was to investigate the association between hypertensive disorders in pregnancy and endometriosis, a systematic review and meta-analysis of 23 studies in total, and the search covered multiple databases up until December 2023, and it revealed a significant association between endometriosis and hypertensive disorders in pregnancy, with an odds ratio of about 1.13 for overall hypertensive disorders, and specifically the odds of developing preeclampsia were found to be 1.26 times higher in women with endometriosis compared to controls. So in terms of their methods, they selected 23 studies in total. The systematic review and meta-analysis adhered to PRISMA guidelines. In terms of the inclusion criteria, it was all observational studies. They had to be published in English. They had to have a confirmed diagnosis of endometriosis. The majority was laparoscopically, or it could be based on imaging. And then in a smaller proportion of the studies, it was by ICD-coded medical records. And then in terms of studies they excluded, studies not published in English, if there is no clear diagnosis of endometriosis, or if full text was not available, or the studies lacked data on exposure or outcome. And then they performed quality assessment of the studies using a down and black checklist. Data analysis, they used Review Manager 5.3, and they found that with the studies, there was no significant publication bias. And then the next slide just is a pictorial representation of how they narrowed down the studies to include. In terms of the main results, so for preeclampsia and endometriosis, there were 12 papers in total which reported the relationship between preeclampsia and endometriosis, which are depicted in figure 3 at the top. There was quite a high heterogeneity between the studies, so they performed a sensitivity analysis, and then following this, they excluded the effect of 3 studies, which then led them to create figure 4. You can see that represented. And the odds ratio they found was 1.26. So in simple terms, the odds of developing preeclampsia in endometriosis patients are 26% higher compared to the control group. And then in terms of gestational hypertension and endometriosis, there were 8 papers which assessed the overall occurrence of hypertensive disorders in women with endometriosis. The meta-analysis showed a statistically significant relationship between hypertensive disorders and endometriosis, but the heterogeneity was extremely high, I think at 93% there. So to reduce this, they omitted the effect of 2 papers on the overall results, which gave figure 7. So with this, heterogeneity was reduced to about 8%, and a statistically significant relationship between the two was identified with an odds ratio of 1.13. So in other words, the chance of developing gestational hypertension was 13% higher in the endometriosis patients. Because in this group of studies, there wasn't enough papers to assess the risk of publication bias. So that's a slight drawback there. In terms of the strengths and weaknesses of this study, so obviously included a large number of studies, a large number of participants, and overall they found that there was a low risk of publication bias. Also importantly, it excluded those who'd conceived with IVF, so it was all just spontaneous pregnancies. In most cases, the endometriosis was diagnosed laparoscopically or on imaging. In terms of the drawbacks of the study, so unfortunately, there was insufficient data to perform subgroup analysis based on endo severity, stage, the woman's age or parity, which could be considered quite important confounding factors. And the study with the greatest significance in the meta-analysis was the one conducted by Belli et al. In 2022, which showed a strong and positive relationship between gestational hypertension and endo. However, there were other studies in the analysis which did not demonstrate a significant relationship between the two. So there was a sort of disagreement between the studies. And the authors acknowledged that we need to perform more longitudinal studies to prove that there is a relationship between these two conditions. So to conclude, from this study of the meta-analysis, it showed that the odds of gestational hypertension and preeclampsia were higher in women with endometriosis compared to those without. But more research needs to be done examining the effect of endometriosis stage, severity, and location on the risk of hypertensive disorders. And the authors acknowledged that the effect of endometriosis on spontaneous versus IVF pregnancies should also be examined and compared.
Charlie, do they offer any explanation on the mechanism?
Nope.
In terms of the explanation, there was a limited sort of description of that. It was more looking at the correlation, I think. Yeah.
Okay.
You know what I always
Charlie,
think?
if they looked at, oh, sorry.
No, go on, Carl.
Did they look at adenomyosis at all?
Exactly my question.
Yeah, no, they didn't, unfortunately, and that would have been one of the limitations of the study as
So
well.
I think the positive thing you mentioned about this study was that looking at individuals with endometriosis and spontaneous pregnancy, I think that's interesting. I think there's been a few others that have tried to separate all these things out as well. I think the bit that's hard is how do we use this information in a useful way? How do we risk stratify these individuals to have further assessment within their pregnancy? I think those bits are hard because I would say, I don't know if other people agree, there's mixed data on this. There's data for and against.
Yeah, we looked at this. I think we've now presented 3 papers on outcomes of pregnancy and pregnancy complications in endometriosis. I can't now remember if they showed specifically preeclampsia or not. I think they did.
Most of them did, Shaheen.
Yeah, most of them have.
I've done one and on gestational diabetes showing a positive correlation.
So I guess a practical question for the UK listeners. So are endometriosis patients now put in the high-risk category and consultant-led pregnancies? Should they be? Is that justified? And if yes, would a superficial endometriosis, which was excised 10 years ago, be the same risk as somebody who had a segmental bowel resection? I think that's, as Kyle says, it's not we're not very clear what to do with this data.
I think for me at least, I think the biggest question is really about adenomyosis. There's probably a good population of those patients that were underdiagnosed with adeno. And adenomyosis to me, it makes sense, right? Because it is placental flow, it is growth restriction, it is preeclampsia. It's like in the UK, I think you're still going to be classed as a low risk patient, but in reality, you should have multiple scans at, I don't know, 20, 28, 32, 36 weeks. And I think that's probably what they didn't look in this study, was adenomyosis, which is probably the culprit.
Okay. But still interesting, open some questions. I think it's an important topic to look at. Okay, thank you very much, Charlie. Flo? Flo is, by the way, the person behind LEJEndo for this year at least. So she's been doing a great job in putting it all together and finding the right, the plans for the next ones. Okay, Flo, what do you have?
So I have a paper which has literally just been published in JMIG last month, and this was looking at dual wavelength laser system, so diode laser on ovarian endometriomas, specifically looking at their effect on ovarian reserve and recurrence rate. And this was published by a group based in Italy. So before going on to the paper, just a little bit about the dual wave laser system. So this is a laser that uses infrared with 2 different waveforms, and through those waveforms, it has the ability to both cut with little thermal spread, but also coagulate. And then I've just compared it there in a table with other more commonly used lasers, perhaps. So CO2, again, with very minimal spread, and also plasma jet, which actually uses cold plasma, so ionized gas, to have that effect on the tissue, again, with very little thermal spread. So this is an image taken from the paper, so the laser fiber in action. So the surgeons have drained and washed out the endometriomas, and then they use this fiber in a sort of a radial way from the center of the cyst to the margins, and it states that it should be done at a distance of 5 millimeters from the cyst wall. Table 2 down here just shows some of the histological evidence. So they took a number of biopsies from 14 of the cases just to show how the depth of vaporization. So they said the optimum depth is 5 millimeters, and that causes a depth of vaporization of 450. It's common sense, but if you're holding your laser further away, you're going to have less depth of vaporization, and closer, you're going to have a greater depth, which might have a knock-on effect of tissue damage. So going on to the paper, so this was a prospective single-arm multi-center clinical trial that was carried out in 4 different Italian hospitals, conducted from March 21 to September 23. The population for the study included 70 patients with symptomatic ovarian endometriomas, and these could be unilateral, bilateral, and they were defined as endometriomas greater than 3 centimeters. They had specific inclusion criteria. These patients were undergoing surgical management of the endometriomas for either pain or infertility, or for both. And then the exclusion criteria, one which was most relevant really to any patient that had previous ovarian surgical treatment, was excluded from the trial. So intervention, so all of these patients underwent the dual wavelength diode laser vaporization on their endometriomas, and they could also have laser vaporization to other endometriosis elsewhere in the pelvis, involving the bladder, the bowel. But importantly, on the ovaries, they had no stripping of the cysts and no suturing of the ovaries as well. Assessment-wise, so they assessed for ovarian reserve through AMH, and antral follicle count, and this was taken at baseline, so pre-surgery, and then also at 3, 6, and 12 months following surgery. They then assessed pain scores in different domains, so chronic pelvic pain, dyspareunia, dysgeusia, dysuria, and for this they did a visual analog score, again at those same time points, baseline, 3, 6, and 12 months. I've mentioned the histological analysis from the biopsies that they had taken after the vaporization, and that was just to assess the laser depth. And then they also looked at pregnancy rate, so looking specifically at spontaneous conception and ART, and also looked at the recurrence rate. So going on to the results, starting with ovarian reserve, and this is depicted by this graph here. So starting with AMH in the top graph A, you can actually see that at 3 months post-surgery, there's a statistical decrease in AMH at 3 months post-op, but actually give it to 6, 12 months post-op, those AMH levels almost come back to pre-surgical levels, and there's no statistical significance between that and pre-op AMH. And then interestingly, looking at graphs B and C, so this is looking at antral follicle count. So B is looking at the ovary that has undergone the laser vaporization, and graph C is the contralateral ovary that hasn't had any surgical treatment. So you can see that in graph B, actually at 6 and 12 months post-operatively, there is a significant increase in antral follicle count. And then on the contralateral ovary, the AFC stays constant, as you'd expect throughout that time period. So the authors propose that actually through the treatment of the endometrioma, through drainage and through the vaporization, you're actually initiating the primordial, primary, secondary follicles to then sort of regrow and increase your AFC, and then that subsequently increases your AMH, which is shown at 6, 12 months, shown by graph A. But then another thing I thought, you're draining these large endometriomas, perhaps pre-surgically, actually for a sonographer to accurately calculate the AFC, it might be that actually pre-surgical, that's an underestimation. I don't know whether that would account for this significance, but it's something just to bear in mind. Going on to the pain reduction, so in all 4 of those domains on the VAS scores, they showed that actually there was significant decrease in pain, and this was sustained over the 12-month period. Then they looked at pregnancy outcomes, which was also interesting. They looked at the subgroup analysis of just the infertile patients, so those patients that weren't able to conceive naturally for over 18 months. And that was 29 patients of the 70 included in this study. And they showed that 48.3 of these patients conceived within 12 months. And breaking that down, 11 of those were natural and 3 were within their first round of IVF. So that the authors suggested that these were in fact better outcomes compared to ART alone in untreated endometrioma patients, which I think is 35%, 35.1% in current literature. So they're increasing it to 48.3 based on their results. And then finally, they looked at recurrence, and this was sort of the most impressive. They said that actually the recurrence rate, so that was defined as the recurrence of an endometrioma at least 2 centimeters in the ovary that was treated, was only 5.7%, which is really low when we consider that cystectomy, which people accept has got the lowest rate of recurrence, is looking at the literature is about between 9 and 20% recurrence rate. I know in LEJEndo we've spoken about alcohol sclerotherapy, and Adrian Crestani presented his paper, which showed a recurrence rate of 11%. And CO2, I think, is I've written it down. I think CO2 has a 18% recurrence rate. So actually, in comparison, a 5.7 recurrence rate is exceedingly low. But then they actually only looked at this over a 12-month period. So whether you're missing out longer term recurrence rates with this data, it is definitely a possibility. So limitations. So although these results are promising, there's no control group. So, you know, it's not comparing it to cystectomy, it's not comparing it to alcohol sclerotherapy or other means. And so that is needed to validate these results. I've spoken about the short follow-up duration, just 12 months. It's a relatively small sample size. So there's a question as the generalizability of the results. I've spoken about the AFC measurement, whether that has any effect with there being a large endometrioma present. And also a degree of selection bias. So this was a single arm trial that may introduce bias. So although these results in conclusion are promising, as always, there's needed for RCTs to validate these over a longer period of time to show that these results are true and effective.
It's always frustrating to see that the data is confusing. You know, ultimately, we want to know how to counsel our patients sitting in front of us with endometriomas, with pregnancy wishes. And these are the most challenging conversations because the data points to all sorts of different directions. I can't really trust the surgical data for various reasons. One is, okay, so this is a good example. You're talking about CO2 diet, this particular type of laser. We all know that you can treat the inside of the endometrioma line by line and be very meticulous and go through each line and each point of that endometrioma. And you can also do a much less complete treatment. And the standardization of that so that you can put it all in a study and say, this treatment leads to that. Therefore, it's becoming very difficult because it's surgeon dependent, it's case dependent. You can't really control for size, particularly because you will have a range of sizes, but they're not going to be the same. But still interesting and reassuring to see that perhaps evaporation of the cyst wall does have a positive effect on antral follicle count. Maybe the point you made is important. Before we carry on, there are a few questions. I think they all go back to Charlie's presentation. So I don't know if Charlie, you can answer these. Do we think the effect of endometriosis, so Mona is asking this, do we think the effect of endometriosis is present regardless of surgical treatment of endo, a history of surgical treatment? So do we reverse the risk basically by removing the endometriosis? I don't know if the study looked at that.
No, I think it's difficult without understanding, or the authors didn't really go into how the pathophysiology or, you know, the inflammation of endometriosis could then result in gestational hypertension and preeclampsia. So I think it's difficult to answer that one.
I
think, yeah, go on.
Sorry,
and then
having
just we
had a few studies that have looked at we looked at similar things. We don't have the data to say essentially, and if that individual has adenomyosis that remains present, then the risk, theoretically speaking, essentially remains.
Mm.
And Latif Akinola, our colleague from Nigeria, is asking the same question we asked, really. Should we therefore screen pregnant women with endometriosis for PET early on in the pregnancy? I can't remember what we did. We did uterine artery, Doppler, and that kind of thing. Do we still do that?
Yeah, so
Yeah.
I was thinking about this. Should individuals who've got known, say, severe adenomyosis, should they be having a uterine artery Doppler, and should we be considering giving them aspirin before 16 weeks? And again, the answer is not 100% sure. There might be other mitigating factors which mean they're on aspirin already. So then I think it's a case by case assessment as to whether you think they benefit from uterine artery Dopplers at the appropriate time, and therefore how should that dictate their serial growth assessment?
Okay, perfect. I think, Charlie, we're back to you now.
Yes. So my next paper, I've got a background in infection and immunology. I did a BSc in uni about it. So this was particularly interesting to me. So it's a pilot study of an IL-1 antagonist, anakinra, for the treatment of endometriosis. It was published by Sullender et al. In the International Journal of Women's Health also last year. So a bit of background. So we know that inflammation plays a central role in endometriosis pathophysiology. IL-1 is an inflammatory cytokine, so it's a key mediator. It's released by macrophages, which are immune cells. And we know that there's elevated levels of IL-1RA, which is a receptor to IL-1 in women with endometriosis. BDNF is another key biomarker which is shown to correlate with inflammation in disease process and the pain of endometriosis. And so this study used anakinra, which is an IL-1 antagonist normally used to treat rheumatoid arthritis. And they were trying to see if it could potentially benefit women with endometriosis. We know that anakinra has been proven to be safe in animal studies regarding fertility and fetal outcomes. And so this study hypothesized that anakinra could reduce pain and inflammatory markers without affecting women's menstrual cycles. And its antagonism of this pathway is something that remains unexplored in the context of endometriosis. So the key points, this was a randomized, double-blinded, placebo-controlled trial. Data from a small number of participants, so 15 participants, over the course of 6 menstrual cycles was collected. The eligible participants had surgically confirmed endometriosis or recent imaging findings consistent with endometriosis and were aged between 18 and 45. They were then randomized to receive either anakinra or a placebo and self-administered these injections during their menstrual cycles. And then the primary outcome they were looking at was the improvement in dysmenorrhea as measured on the BMB scale and VAS scale as well. And then the secondary outcomes were quality of life changes, menstrual cycle length, and in the inflammatory biomarkers as well. So in terms of the results, 17 women completed the study, but with only 15 providing the full data. There was no significant demographic differences between the 2 study groups, as you can see in table 1. So, roughly the same age, ethnicity. The only, I think, significant difference I noticed was that, I'll come on to that later, actually. And then the groups were divided into Group A and B. So Group A received anakinra for 3 months, and then placebo for the remaining 3. And then Group B had vice versa. So they had the placebo and then anakinra. And then what the authors found was that the BMB score and the VAS score trended towards improvement with anakinra, but it was not, unfortunately, statistically significant. They also used the EHP30 scoring system as well. And some of those domains actually did show statistically significant improvement with anakinra in the domains I've just circled: control and powerlessness and self-image. And then next slide. So this was table that was looking at the biomarkers. So the BDNF, which was another one of these inflammatory mediators, the levels significantly decreased during the use of anakinra treatment compared to placebo. And then IL-1RA and IL-6. IL-6 is another inflammatory cytokine. The levels showed significant differences between treatment conditions. Other biomarkers did trend lower with anakinra, suggesting potential anti-inflammatory effects. And then the menstrual cycles of the women were preserved during the treatment with anakinra. In terms of the strengths and weaknesses, so, you know, it's good study design, it's randomized, double-blinded, placebo-controlled, crossover design. So each participant actually kind of serves as their own control because they have a period of time receiving the active medication and then a period on the placebo. So this minimizes variability and allows for better comparison, I think, of the effect of anakinra and placebo on the same individual. There's a focus on quality of life as well as pain management. And so it looks at the effects of anakinra in a sort of broader context. It's a potential non-hormonal treatment. Thus far, you know, all the medications that we use for endometriosis are contraceptive, hormonal. And so anakinra provides a sort of exciting alternative, which may allow women to conceive whilst taking it. Obviously, drawbacks, very small sample size, only 15 women managed to complete the study with all the data. They actually recruited initially 35, but they had quite a large dropout rate. And the main reason for that was actually because it was this study was published during the COVID pandemic, and so some women were concerned about taking an immunosuppressive drug during the COVID-19 pandemic. And then in terms of the findings, so some of it was not statistically significant. So although the VAS scores and the BMB scores trended towards improvement with anakinra, the results were not statistically significant. So it suggests that we need to basically carry out larger studies. And to conclude, I think anakinra could serve as a long-term non-hormonal therapeutic option that does not disrupt fertility, which is particularly important for women trying to conceive. And while the study showed trends towards improvement in pain and quality of life, many findings was not statistically significant. So we'll need to potentially put these out on a larger scale.
Yeah. So basically, just to reword your conclusion, it can't be recommended yet.
No, exactly.
Because we haven't proven effectiveness.
Yeah.
And also, you know, you as the immunologist in the group, I've done my MD in immunology, by the way, but I've forgotten that. So is the idea that by reducing the interleukins, the symptoms will improve, or is there a suggestion that actually it plays a role in the pathophysiology and therefore it may have some effect on the actual disease?
I'm not sure.
Because if it's the latter, if it's the former, if it's okay, we'll reduce the inflammatory the interleukins and therefore the pain will get better, then my next question will be then if it's just a symptomatic medication, what's wrong with the normal symptomatic medications, non-hormonal?
But I think, yeah, I think I think we know that inflammation plays a role in endometriosis, and if you're literally suppressing the inflammation itself at a sort of cytokine level, then you are sort of modifying the disease process, I guess.
Yes. Okay. Interesting. But, you know, just worth remembering that none of the medical treatments will actually solve the problem, will they? Till now. So Charlene Reese is asking, is any screening available for daughters when their mother has had endometriosis and adenomyosis? And Charlene, the answer is we have some tests now available in the market, but for a test to be a good test for screening, there are multiple criteria that need to be met. And as of yet, we don't have something that will fulfill that criteria. I think the best thing to do would be to keep an eye on symptoms. And if there are symptoms that are suggestive of endometriosis, then see someone with a specialism in endometriosis and get some assessment. And that would start from an ultrasound scan. Usually a good ultrasound scan would be a good starting point. But yes, we do know that daughters of women with endometriosis are much more likely to have endometriosis. Up to 8 times have been mentioned, although other studies have quoted lower numbers. Okay, thanks, Charlie. We've got Pavle, Avril, and Kyle now. So let's go to Pavle.
Sorry, just unmuting myself. So I think touching on fertility that Charlie was talking about as well, I think one of the burning questions that we have is, especially from our fertility colleagues, is whether or not endometriosis surgery before artificial reproductive techniques, so either IVF or ICSI, leads to improved outcomes. And this is an interesting paper from our Parisian colleagues, Bourdon et al. It was published in Reproductive Sciences in January 2024. And so, pardon me. So at the time of the writing of the paper, no randomized controlled trial for pre-ART surgery comprising of all the different phenotypes of endometriosis versus conservative management existed. So they performed a systematic review and meta-analysis of observational studies focusing on the comparison of ongoing pregnancy rates and live birth rates between patients who underwent endometriosis surgery for ART and patients who are referred to first-line IVF, ICSI. The primary outcomes were looking at these two things, so ongoing pregnancy rate and live birth rate, which is obviously very important for these patients. And secondary outcomes were clinical pregnancy rate per cycle, clinical pregnancy rates, ongoing pregnancy rates, and live birth rate per transfer. Cumulative values of these following all cycles, early pregnancy loss rates per cycle and per transfer, and obviously adverse outcome rates. In terms of the methodology, so it was a literature research, was undertaken looking at articles that were either available in French or English from January 1990 and 1991, and that was carried out across PubMed and BASE and the Cochrane Library. 2 independent reviewers screened titles and abstracts to select the relevant studies and assess methodological validity in resolving disagreements through discussion. Data extraction was performed using standard form, and they looked at study design, patient demographics, and the surgical treatments involved. Importantly, and I think this was really nice about the study, is that when certain information or data was missing about outcomes, they contacted the original author at least by email twice. So they really tried to get as much information as they could. And if there was an absence of data, so if there was no response from the authors, there was no data available, article with outcomes only expressed as percentages were excluded. And when data was dispatched into subgroups in the article, extracted data was pooled for overall meta-analysis. The 2 reviewers assessed using the Newcastle-Ottawa Quality Assessment Scale for study quality and the Robbins I tools for risk of bias. In terms of data analysis, you can see that they used odds ratios with a 95% confidence interval. Heterogeneity was using the Q-chi-square test and I-squared statistics, and publication bias was evaluated through a funnel plot. In the study, the control group was obviously women who were diagnosed with endometriosis, who underwent IVF or ICSI with no previous surgery for endometriosis, compared to the other arm, which was women who underwent surgery prior to this treatment. On the right-hand side of the screen, we can see the Prisma, which shows that there are initially 2,109 studies included. Removal of the studies included duplicates, out of topic, or main outcomes missing, which resulted in 22 papers, 3 of which were further removed due to missing data, and it resulted in 16 cohort studies, 2 case controls, 1 randomized control trial, but in a prospective cohort, and overall 2,444 women were included in the study, of which 1,460 had endometriosis surgery before ART. Overall, it's quite a lengthy paper, but overall they find that no significant benefit of endometriosis surgery before ART was found regarding live birth rates for either live birth rate per cycle, which is A, that we can see there on the forest plot, or B, cumulative live birth rate, which is underneath. On the right-hand side, we can see a risk of bias legend that shows that the quality of the evidence was rated predominantly low or very low for confounding factors, selection of participants, classification of intervention, and also with obviously missing data. Ongoing pregnancy rates were reported, sorry, still on that slide. Ongoing pregnancy rates were only reported in 3 studies, and meta-analysis of these found, again, no significant association of endometriosis surgery with overall per cycle, per transfer, or combined ongoing pregnancy, cumulative ongoing pregnancy rates. When they did subgroup analysis, they focused on the type of endometriosis surgery and the endometriosis phenotype which was performed to explore statistical heterogeneity. As you can imagine, endometriosis is quite an all-encompassing disease, and they acknowledge that they're not able to look for superficial endometriosis, but they looked at deep endometriosis. And in terms of the information that was available from these studies, they found that cystectomy showed no no impact on live birth rate per cycle. However, interestingly, ethanol sclerotherapy, which we can see sort of on the third side on the left-hand side of the screen, demonstrated a statistically significant higher live birth rate per cycle compared to no intervention before IVF or ICSI. When they looked at the subtype of endometriosis, there was very limited data available, but once again, they found no impact of surgery, with only 1 paper, which is by Mangian et al., which found a live birth rate per cycle in the no surgery group. Like I've mentioned, they weren't able to find data for any superficial endometriosis, and clinical pregnancy rate and early pregnancy loss showed no significant difference for either arm of the study, and only 3 studies, which is pretty poor, I think, reported safety data on infections or hemorrhage, and once again, there was no difference in groups between those who had surgery and those who did not have surgery. In terms of the strengths and limitations, it's a very difficult study that I think they tried to do. It's the first that they had a look at examining the endometriosis surgery's impact on ART outcomes across phenotypes. They had a good methodology and they accounted for risk of bias. But obviously, I think there are quite a few limitations with this study. They're all observational, which means they lack adjustments for confounders, which is a really big impact in the meta-analysis. Unreported systemic comorbidities and hormonal treatment histories weren't included in all of the papers. Important details such as the lesion types or locations, previous surgeries were not available in all the papers. And several studies they found had actually quite a high risk of bias for inclusion and excluding endometriosis reoccurrence, cancelled ART cycles, the works. There was also, as you can imagine, a high heterogeneity amongst included studies, which presents another limitation. For their summary, they find that lower live birth rates were observed in patients undergoing surgery before ART compared to first-line ART when they excluded high-risk studies, but overall there wasn't a difference. Sclerotherapy was found to be beneficial for live birth rates per cycle, but ultimately fertility preservation should be integrated before surgery in the therapeutic strategy for these patients. And once again, we go back to the same point that it needs to be a patient-centered, interdisciplinary approach in endometriosis management, and that we need to weigh up the risks and benefits of surgery before proceeding with these patients.
Okay, Pavle, thank you very much. All right, we have only 5 minutes and 2 more papers to go through. Avril, so Avril joined us a little bit late today. You all know Avril. Please, what are you showing us today?
Okay, good evening, everybody. So today I have a paper that was published back in 2023 by a group in Ontario, Canada. And they looked at the risk of cardiovascular disease in patients with endometriosis. And the whole reason they wanted to do this study is not only to stratify this risk, it's because that there's been 3 studies done about it, one in Boston, one in Taiwan, and one in the UK, which showed an increased risk. So they wanted to contribute to the growing body of evidence. Next slide, please. So this is a population based matched cohort study. They used data from the Ontario Health Insurance Plan, and they looked at patient aged between 18 to 50 years old with a diagnosis of endometriosis between 1993 and 2015. And they matched this to 2 patients without any diagnosis of endometriosis based on their age on geographical location of residence. Patients were labeled as endometriosis if they have at least 2 medical diagnostic codes, either in the outpatient setting, inpatient hospital diagnosis, or hospital admission for endometriosis. And patients were considered to have surgical confirmation of disease if they have had a medical diagnosis and a qualifying surgical procedure. The first date of diagnosis of endo served as the index date, and the primary outcome was looking at hospital admissions for cardiovascular disease, and the secondary outcomes were in-hospital cardiovascular disease events of interest and any emergency department visits related to it. Next slide, please. The exclusion criteria was patients who had cardiovascular disease parameters before the index of diagnosis, if the endometriosis diagnosis was outside the study window, and if there was any missing data. So, in terms of the results, for endometriosis, there was 166,835 patients, and those without endo is 333,706 patients without endometriosis. What they found in terms of baseline characteristics was that a higher proportion of patients with endo were nulliparous, 65.3% compared to those without, that is 59.6%. In terms of obesity, diabetes, hypertension, they were similar in both groups. Surgically, patients with endometriosis were more likely to undergo bilateral oophorectomy, so 19.5% versus 2.7%, and also a hysterectomy, so 46.6% versus 7.6%, and also to receive a diagnosis of premature menopause. The mean age of menopause was also slightly lower in the endometriosis group, so 42.97 years old versus 46.18 years old. Okay, next paragraph, please. So what they found was patients with endometriosis had an increased risk of hospital admission for major cardiovascular events. So this included acute MI, stroke, congestive cardiac failure, needing a graft, ischemic heart disease, or cerebrovascular disease. They were also at a higher risk of a secondary cardiac event, so like unstable angina, cardiac catheterization, peripheral
So sorry,
vascular.
April, to interrupt you. So is that corrected for patients who've had a hysterectomy or
No,
oophorectomy?
unfortunately not. They did not
So,
do any
okay.
sensitivity analysis on these.
So that may be simply due to the hysterectomy, no? Because as you showed in your previous slide, the patient with endometriosis were much more likely to have a hysterectomy and bilateral oophorectomy. Okay.
Yep, I completely agree. And the study that was done in Boston did show that those who have had these surgeries were at an increased risk of cardiovascular disease. But this paper didn't mention any of that.
Okay.
Yes, they did look at whether premature menopause altered the results. Again, their sensitivity analysis did not show that premature menopause altered the results or increased or decreased the risk. But then again, when they say premature menopause, they didn't comment on whether it was surgically induced premature menopause or it was natural premature menopause. And they did mention that this is one of the limitations of their studies.
Pretty big limitation, I may add. Is it the endometriosis causing this increase, or is it the hysterectomy? Because it's more than a confounding factor now. If you have in your non-endometriosis group, because they say that they match to 2 patients, but they don't say if they match to 2 patients who have also had a
Who had
hysterectomy.
hysterectomy.
Yeah. Okay. Yeah. Carry on. Sorry.
Yeah, unfortunately, they didn't make any comment on that. So for the next slide, please. Yes. So they also looked at whether the patients had endometriosis diagnosis based on medical diagnosis or surgical diagnosis, and it didn't show whether the results differed or not as well. Next slide. Um, Yes, so this result shows that the patients um, showed that the age at the time of diagnosis affected the risk of any major outcome, with the risk decreasing with increasing age of endometriosis diagnosis. So that means the younger they have been diagnosed with endo, the higher the risk they have with cardiovascular disease. And this was also supported by the study in Boston and in the UK that showed that women who were diagnosed under the age of 40 were at a significantly increased risk than those who didn't. Next paragraph, please. Next slide, please. Yes, so in this large population-based study, endo was associated with a small increased risk of cardiovascular event. Future studies are needed to investigate potential etiological mechanisms and strategies to decrease the long-term risk in these patients. And like I said, their findings agree with the results in the studies done in Boston, Taiwan, and the US. The authors hypothesized that the risk may be secondary to dysregulated immune system, or whether or not endometriosis itself worsens CVD is yet to be determined. Yes, and they could be related to dysregulated inflammation, increased oxygen, reactive oxygen species, and unfavorable lipid profile, or the treatment modalities used to manage endometriosis, such as the medical treatment, the surgical menopause, etc.
Okay.
It's an interesting paper. I like that.
Mm-hmm.
No,
Yeah.
I wonder, Shaheen, what do you think? Do you think that sympathetic nervous system has something to do with it? Increased heart rate in those patients, dilated pupils?
Yeah, as I said, my main problem is that we have a big factor that has been proven to have an effect on cardiovascular disease. We already know when you're comparing two groups, first you need to show that these two groups are comparable.
Yeah.
Okay, in everything else, and the only thing that is different in them is endometriosis or no endometriosis. But we already saw that the two groups that they looked at, unless I'm not understanding the study properly, Avril, we already know that in this study, the group that had endometriosis had a much higher rate of having a hysterectomy.
Yeah.
We already have seen in other studies that having a hysterectomy, even with preservation of the ovaries, even with HRT, is associated with higher risk of cardiovascular disease. So I don't think we need any other explanation because we have one factor that has been proven to account for that. Am I making sense? I don't know. Maybe I'm missing.
So you're making sense, yeah. And they also mentioned it in their limitations. They also mentioned that they didn't look at other modifiable risk factors such as smoking status, diet, exercise, etc.
Yeah. Okay.
Yeah, which is a good point that needs to be included actually. Okay.
Okay.
Well,
Well,
interesting.
we're 5 minutes over time. I think Kyle, you I think we're gonna ask you to present next time. Would that be okay?
Yeah, no, that's fine. That's absolutely
Okay.
fine.
Sorry about that.
No,
So thank you very much, and thank you for everyone who's joined us. This is the next one, so 6th of May at 6 p.m. We're going to present this really interesting study. We have managed to get the lovely people from the Office of National Statistics who have recently published a report on characteristics of women with endometriosis in England. And that is a 10-year data with really detailed information that is coming out of ONS. And ONS, for those of you who are not familiar with it, is an office in the UK that basically looks at number crunching and looks at data in a national level, at a national level. And we thought this was quite interesting. And it's a recent publication, just came out December. So I look forward to seeing you all there. And thank you again for everyone who presented, Charlie, Avril, Pavle, Flo, and well, Kyle as well, although you didn't present. Okay. Thank you very much, everyone, and thanks, Mikey, for helping and sharing the session.